רוצה את זה באנגלית על מנת לשתף גם את דן בדיון. Two cases that have to do with therapeutic dilemmas with the treatment of the bigotron. The first case is a case of a 73-year-old male with unstable angina that requires urgent coronography and also intervention. This is the story. It's a 73-year-old male who is on the bigotron for atrial fibrillation, started several years ago. The last dose of the bigotron was given 17 hours earlier. This is his other history, background of hypertension, congestive heart failure, vertebral artery disease, stable angina, erosive gastritis, and anemia, and he is on all these medications. He comes in, these are the vital signs. He presents with unstable angina, ACS, acute coronary syndrome. He needs urgent coronography, likely to need intervention. These are his blood test results. He has APTT of 44. Here you have the normal values. The thrombin time is extended. Direct thrombin time and ecrine clotting time. These are all abnormal due to the treatment with the bigotron. So at this point, patient presents with on the bigotron. Although he's 17 hours following the last dose, he's still by the blood test. He's under the influence of the bigotron, and the question is what to do now, and whether we need to give him an antidote. Let me stop here and refer the question to the panel. Dan, would you like to comment on this?
So this is open for discussion. We ask all the speakers to come close. So as you have seen, this is a case of non-STEMI or unstable angina, and with a pre-dosage of the NOAC already integrated. And what is the opinion of the panel regarding the need to circumvent the NOAC effect? Hi.
Well, it really depends upon the condition of the patients. I can tell you that today we're switching a lot into radials, and it really depends in my hands whether you're going to do a radial or a femoral approach. I think that those who have experience with radials know that you can most of the time control the situation with even if the patient is on NOACs or in Coumadin, and therefore I wouldn't stop it. Also, I do not want to destabilize the coagulation system in a patient with acute coronary syndrome. So if it's not a femoral approach and not a big thing, I wouldn't do it.
So that's very interesting, and obviously it shows that we have indications for using the NOAC that are discussable, where there is no complete agreement, and we, in this case, really can consider to use it or not to use it. Professor Rosenbaum, would you like to have a comment?
I fully agree with Chaim. I think this patient has, although we can't quantify exactly the amount of coagulopathy, but it looks as if it's not a very bad effect of the bigotron at this point. The PTT is very mildly elevated, and diluted thrombin time is only mildly elevated. Doesn't put him at a high risk of performing the catheterization. We also tend to do radial approach, so under these circumstances, we are less concerned about the possibility of bleeding. If the patient is extremely stable, maybe we would consider postponing the angiography a little bit to stay away completely from that. If not, I think we can proceed with our routine practice. We had unfractionated heparin during the procedure because we are not convinced that the bigotron is enough to prevent catheter thrombosis or stuff like that. And the only situation that we might consider under these circumstances to give the antidote is like if the patient develops severe bleeding after the procedure, and we can control it under these circumstances, we would use the antidote, but not before the procedure.
So these are very important aspects, and we remind ourselves that we here have a 17-hour time window during which the dabigatran already is starting to have less effect, and according to the non-STEMI guidelines, the newest ones, it's okay to postpone an angio to 48 hours. So
on the other hand, if you need to send the patient to surgery or urgent surgery, then it's a viable alternative.
Yeah, very, very well. Any comment from the audience?
Just a comment that this approach these are actually real cases out of the study. So this was a case that was actually given the antidote. There are very few cases, I mean, in the literature to base this decision on, but it has been used in several patients who went to PCI.
So maybe you would like to show us how this case went on?
Okay, so the patient received an antidote, was admitted to the CCU, and then following a successful PCI was started on unfractionated heparin, clopidogrel, aspirin, and atorvastatin. And at this point, I would like to ask you about the treatment down the road, from this point on. He was discharged probably 1 or 2 days later, and the question is, what's next? What's the treatment next? And let me just maybe help you with this here to make the decision. Okay, this is what we have. I mean, whenever we do a discussion of the future treatment of a patient who is on anticoagulant and underwent PCI, we need to do some preliminary evaluation of the CHA2DS2-VASc and the HESBLED, and this is what you have here. His CHA2DS2-VASc is 4, congestive heart failure, hypertension, age and vascular disease, and his HESBLED score is 3, which is fairly high. So what now?
So this is really a very exciting topic, but at the same time our daily headache, namely the comorbidity of acute coronary syndrome and atrial fibrillation and the need for anticoagulation and antiplatelet therapy. Please give me a sign from the audience if you want to have a comment to this. But let me ask first, given here CHA2DS2-VASc of 4 and a HESBLED of 3, what would you recommend in this patient?
Well, like you mentioned, it's a complex cases, but it's our daily practice where you have to give triple therapy, what is mentioned. Unfortunately, there is not enough data on triple therapy, especially not on the combination of NOACs and the new antiplatelets, which might be too little or too much. So today, our routine practice, and it may change in the future, is coming back to the NOACs, and in this case, the patient was successfully treated on the dabigatran, so he should restart the dabigatran after, I think, 24 or 48 hours once we are sure that the procedure is successful. And then we have to think about the addition of antiplatelet. Aspirin definitely is the one that everyone will go, and the question is, should we add another potent antiplatelet like prasugrel or ticagrelor, or should we go to Plavix? Today we are choosing something in between, and we're choosing Plavix and aspirin together with the dabigatran. The question is, for how long should we give the triple? And it really depends on the stents. Today, our willing is to give only for 1 month because antiplatelet is to fight against thrombosis, and we do know that stent thrombosis in more than 90% occurs in the first month. So we would give triple antiplatelets, triple therapy, dual antiplatelets for the first month, and then take off one of them, usually Plavix.
We actually follow very similar situation. I think that in these specific cases, you have to take into account both the CHA2DS2-VASc score, the HESBLED score, but one thing else that Chaim mentioned is the complexity of the PCI and the complexity of the stenting procedure. we also at this point don't use the new antiplatelet agents. We stick to clopidogrel, even though in studies we are also using, in some of the studies we are also trying to use some other antiplatelet agents. Regarding the longevity of the triple therapy, it really depends also on these parameters, the HES-BLED score and the complexity of the PCI procedure. Our routine approach is to use triple therapy for 1 month, as Chaim mentioned. Contrast to this case, we don't stop the clopidogrel after 1 month. We stop the aspirin after 1 month, and we continue with the clopidogrel. And we maintain double therapy for usually, if it's an acute coronary syndrome, we maintain the treatment for 1 year, and after 1 year, we stick to anticoagulation alone. But I think that we are still awaiting some data regarding the appropriate use of triple therapy with different combinations or double therapy with ongoing studies. The one thing that we do change is we reduce the dose of the dabigatran to 110 instead of the 150.
That's an important point that I want to ask you about. It's a sensitive question because remember where we are, but what kind of novel anticoagulant and the dose? Do you continue with the bigatran, Chaim, or change to other thing, or what about the dose?
Well, I don't see a reason to not to continue with the bigatran. You have experience with before, and now you have an ability to stop it when you want, so I don't see a reason to stop it. The question is which kind of dose do you give, and there is really no data about it. I think that in my case, if the patient has all the criteria to continue with 150, we'll continue 150. But again, in the lack of data, if you want to say that I will give 110 because you know the coagulation system is a little bit fragile, then it's okay. You have to look at the HES-BLED and the patient, and a HES-BLED of 4 is kind of in between, and if you want to be a little bit on the safer side, that's fair enough as well.
So in this regard, there is not scientific data, but an expert opinion on the table. And I know Professor Glikson has a very difficult slide to share with us, which shows something about this combination therapy.
I just want to mention this table that comes out of a seminal paper by Lip that deals with the anticoagulation in ACS patients. I don't want to follow all this very complex diagram, which I have on my smartphone, by the way. It's very comprehensive and gives you the answer to many questions. It's published in 2014 in the European Heart Journal. But this patient, if you measure the patient, measure the Chadvask and the HES-bleed, this diagram leads you according to the level of the Chadvask and the HES-bleed, you're being led to the suggested treatment, type of treatment, and duration of treatment. And this patient falls into this classification of triple therapy for 1 month and then dual therapy for the rest of the year. Some people might even omit the aspirin on the first month in this case, so this is also an option. And then, in any way, you continue with dual therapy. Regarding the type of the novel anticoagulants, there is a hint in a very recent paper published in the European Heart Journal in 2 parts dealing with choosing the anticoagulant in various situations. I strongly recommend looking up this reference because it gives you, again, an expert opinion, but a fair answer to many situations. One of them is a situation of patients following ACS, PCI, and stenting, and they come up with a recommendation for a reduced dose novel anticoagulants. And it's very important to realize that whereas the bigatran 110 BID was actually tested in the studies, none of the other novel anticoagulants in reduced dose was tested in the general population. So I think that we have a good reason to give this patient the bigatran 110 BID.
That's a very, very interesting point. In fact, it is written somewhere that the NOACs should be utilized in the lowest tested dose, and this is really addressing what you are saying. Is there any comment to this case from the audience? Then I propose that we look to the next case.
Yeah, we'll probably have to, we'll go quickly through one more case. And this is a case of a 70-year-old female who is on the Bigatron 110 BID for atrial fibrillation, commenced 1 month earlier. The last dose was given 10 hours prior to admission. She has sick sinus syndrome, mitral regurgitation, and aortic regurgitation. She's on metoprolol, hydrochlorothiazide, allopurinol, and methotrexate. And she presents to the hospital with sinus pulses up to 12 seconds with syncope. She needs treatment, that's for sure. There is no option just to wait and see, and she requires urgent intervention. So what are we going to do at this point, gentlemen?
Well, Dr. Rosenman?
Well, sick sinus syndrome, patient who requires a pacemaker, that's for sure. Obviously, there are two options: to put a temporary pacemaker, or to put a permanent pacemaker. What we try to do in our hospital, if the situation is such, if the facilities are such that we can go ahead and put a permanent pacemaker, then we go ahead and put a permanent pacemaker. Obviously, under these circumstances, there is an issue of bleeding and pocket hematoma, and we try to avoid pocket hematoma because there is a recent publication from Canada that suggests that pocket hematoma increases tremendously the risk of pacemaker infection, and that's something that we are very worried and we want to avoid. So if we have all the setup that is ready to do a permanent pacemaker, we would definitely continue with the pacemaker, and we would use the antidote in order to reduce the risk of this pocket hematoma and to get the pacemaker safely. Then we would wait 2 or 3 days after the procedure, if the procedure was bloodless, before we resume the Bigatron. That would be our approach. If we don't have the setup to put the permanent pacemaker, then we go ahead and put a temporary pacemaker, and then the issue of using the antidote is becoming less relevant.
Thank you very much. Let us review the course.
Chaim, would you go the same way, or would you rather? I'm not sure that I wouldn't put a temporary pacemaker for 12 or 24 hours, but I think it's an option. If it's done, it should be done in the femoral.
It's up to the patient's condition. We also tend not to put temporary if the patient is stable, and try to put a permanent as quick as possible. If you go through the femoral or through the here, you're still running a lot of problems, and if the patient is heavily anticoagulated, you can run up into hematomas. So I think that actually this case is a very good indication to stop anticoagulation, to put a permanent pacemaker, and within 24 hours or 48 hours, start again.
Let me just tell you from my feeling that soon enough we will start putting pacemaker on novel anticoagulants, as we do with ablations now. And there are actually some preliminary work done on both apixaban and on the Bigatron in implanting devices. But at this point, I think that you're right. You have either wait or give an antidote, and this is what they did. And again, this is a real-life case from the study. They gave an antidote, did the procedure, and what now? Can we start the Bigatron? When can we start the Bigatron?
First of all, what was very nice in these slides is to see how quickly everything is reversed. And I think that, again, this should be emphasized, that within hours, and you don't have it with other options, within half an hour, you're getting normal hemostasis. So if you're planning a procedure, you can stop at 7 a.m. and 8 a.m., have the patient in the operating room, and with everything else. When to restart is really dependent upon your coagulation and upon the bleeding. If you have a small pocket and it's dry, I think within 24 hours you can restart.
I may maybe add what the policy would be in our institution. we would clearly see an indication for the antidote here, as outlined in this case, and we would not advocate for a temporary pacemaker, but move towards a permanent implantation. Michael?
Yeah, we probably need to look again, in any such case, we look at the risk, benefit and risk for bleeding, risk for thromboembolism. The risk for thromboembolism is not very high here. We don't have to rush. I mean, she has a child vasc of 2. It's not, I mean, I wouldn't consider resuming the therapy very early. She can wait 2 days. I must emphasize that the has bled in this case, I think, is irrelevant. We treat pacemaker implantation as a high risk for bleeding. Although it's a very minimal bleeding, it will ruin the procedure, you will have to take it out, and you will have to stop anticoagulants for a week. So that's why pacemaker or device implantation is a kind of a high-risk situation. So low risk for thromboembolism, high risk for bleeding, I would wait 2-3 days and then resume the anticoagulant. What do you think?
That's very much in our line. There is a comment from the floor, please. Yes, please. Just speak up very highly.
I think it's more complicated to do a pacemaker than to do a therapy rather than doing it on anticoagulation. It's not uncommon that somebody comes with similar situation. I personally find it much easier and much more safe to do the pacemaker with good hemostasis under Coumadin. I didn't do it under NOAC, rather than do it under dual antiplatelet therapy, especially to.
Yes, I see your point. Thank you.
We have 5 more minutes, so why don't we discuss rather than rush into another case? I think it will be too short.
We have still the opportunity to hear opinions from the audience.
It's important to mention, though, that we do devices under full conservative anticoagulation by Coumadin, and it's considered much safer, even as far as bleeding, than doing all the exchanges with Glikson, with heparin or low molecular weight heparin.
But you know, Michael, I must a little bit disagree with you, because I think that you do it because of the problems that you have with warfarin. But with the NOAC, I think that, and forget about all the financial issues, assuming that you can use the antidote with no limitations, I think it's very attractive to have a patient under full anticoagulation with the NOAC, to give the antidote, and then within 20 minutes, half an hour, you are with normal coagulation. Do the procedure with normal coagulation. Don't risk having a pocket hematoma, and pocket hematoma, as we have discussed, is associated with additional potential future complication, and then resume the anticoagulation with one of the NOACs, and you don't have to wait a lot until you achieve adequate anticoagulation.
Correct, but when do you resume it?
What?
When do you resume the novel anticoagulant?
Okay, but if you believe that you can do the procedure under full anticoagulation with warfarin, for example, then you actually expose the patient to prolonged bleeding during the procedure and afterwards. So when to resume, it really depends on the risk of stroke. If the patient has a very high risk of stroke with a Chaz vasc that is extremely elevated, then you would resume the NOACs within maybe a day. And if it's low risk, then you would resume the anticoagulation after 4 days. But definitely, when you resume it one day or 4 days after the procedure, the risk of hematoma is low as compared to performing all the procedure under anticoagulation.
I'm not sure. There was an extensive study. I'm trying to recall the name of the study. Nimel, you remember? Big study on full anticoagulation for device implantation, INR between 2 and 3, completely safe. And this is
yeah, but not when you do it, when you have the option. You're talking about bridging or not bridging and waiting. But one of the advantages of these NOACs is that bridging is not becoming an issue anymore. You don't have bridging with the NOACs. That's one of the major advantages of them. And I think it makes much more sense to control the coagulation with the antidote and then resume anticoagulation when you feel it's safe, and don't perform this procedure under anticoagulation. That's my feeling. I know there is no study on that, but I think it makes it, well, okay, so we'll see, we'll wait for the result, but I think it makes more sense to do surgery on normal coagulation rather than perform surgery under anticoagulation. That's my feeling.
Okay. Any more comments on or questions?
Very well. You have...
No, that's for the next case.
Okay. So I think we have discussed very nicely how a antidote indication can arise in such a situation, an acute need for hemostasis. The question about reuptake of the NOAC is a bit differential, either next day or after 4 days. I don't think it matters so much, in fact. The risk for stroke in a 2-day window is really very, very low, so I don't think it matters so much. You can also look at the CHA2DS2-VASc as we have seen. I mean, CHA2DS2-VASc 2 in itself is already a NOAC indication for SPAF, so we are in any case covered with this indication to continue. Are there any remarks regarding this case? Chaim, do you have any remark about it?
No, actually I think that we have to start using it and to train ourselves. I definitely agree with Professor Rosenman that we are doing things because we didn't have other alternatives. So we trained ourselves to do it on Coumadin because going back off and Glikson and back and forth, we had more problems. But now that you do have the alternative and you can stop half an hour before the procedure, have completely dry field, and then resume a day or 2 days later, will definitely be a big change and a big help.
I very much agree to this, and I must say that primum nil nocere, we have heard about the devastating experiences from pocket bleeds. Our own center is a regional center for extractions, and we have looked at our first 1,000 extractions of devices, and many of those are linked to bleeding complications. So now that we have an antidote, I think it's a very good indication indeed.
One word that bleeding is not necessarily from the anticoagulation before. I mean, the question of when to resume is still a question. I'm not sure that 1 day is enough. We probably have to wait 2 or 3 days.
Yes, I agree. Yes, we'd be on the cautious side. And you make sure there is complete hemostasis. So I'd like to thank all the excellent speakers and the faculty, Professor Glikson as a co-chair. I'd like to thank the sponsors, Boehringer Ingelheim, for this interesting satellite, and the audience for being very helpful today. That closes our session, and thanks a lot.